morning is Research Grand Rounds, highlighting ongoing research taking place in our department. And we are very fortunate to have Dr. Victoria Roach with us. Dr. Roach is currently a research assistant professor and the director of evaluation assessment at WISH, having joined the University of Washington in 2021. Dr. Roach trained at Laurentian University in Ontario in biomechanical biology, and then followed this with a master's degree in clinical anatomy, and finally a PhD in anatomy and cell biology from the University of Western Ontario. Prior to joining our faculty, she did serve at the University of Western Ontario, and then went on to be an assistant professor at Oakland University William Beaumont Medical School in Michigan. She had a primary focus on clinical anatomy education and research communication and scholarly presentations. In addition to her day job, Dr. Roach also served as a research primary mentor for more than 10 medical students, with a large majority doing research projects in the acquisition of surgical skills and simulation training. And also in her relatively short yet illustrious career, she has had more than 20 peer-reviewed journal articles to her own credit, and many of these were focused on laparoscopic skills and simulation training. So Dr. Roach, it is a great pleasure to have you with us this morning. We look forward to your talk. I know it's going to enhance our knowledge and hopefully challenge us as we continue to consider skills training, simulation, and models and their fidelity.
Thank you, Deb, for that wonderful introduction. My goodness, these are the days of your lives kind of thing going on right now. Very excited and honored to be here, and hopefully you find this presentation interesting. So just getting started off the hop here, I have nothing relevant to disclose. So by the end of the session, I hope that we're able to have a solid conversation about the domains of physical fidelity, because fidelity is a much thrown upon word that often isn't operationally defined. We like to define it here in the CREST team in terms of visual, tactile, and behavioral domains, but we'll talk about that more. Also, I hope that we'll be able to recognize the relationship between fidelity and educational utility, and how high fidelity, particularly in reference to simulators, compares across commercially alternative other simulators in terms of efficacy. So how does the fidelity of a model confer skill acquisition? So in order to address those three objectives, I've split this talk up into three sections. In particular, the development effort, which is the building of AJAMS, the Advanced Joint Airway Management System, and then my wheelhouse, the evaluation pieces. So the evaluation of physical fidelity with reference to the anatomic structures that are presented by 3 different airway simulators, and how endotracheal intubation performance in novices differs when training on different simulators based on their fidelity. So bear with me, the first piece of this talk, the development effort, is not in my wheelhouse. It is really discussing the wonderful and impressive work of my colleagues in the CREST lab that went through the process of building the AJAMS model from the ground up. So I will give you a high level picture of it, but bear with me, as I said. The slide's not advancing. There we go. Okay. So the Advanced Joint Airway Management System was a project that was funded by the Department of Defense to the University of Washington, and the PI was my esteemed colleague, Dr. Robert Sweet. So this was a work that was completed between September of 2017 and 2022. So we just wrapped this up last year. So the rationale for this particular work was that there was a deficit in existing training for frontline workers in the administration of the point of care for airway management. This was addressed through literature and through anecdotal evidence in a previous study conducted by my colleagues here, Dr. Robert Sweet and David Hananel. They identified this need through the Advanced Modular Mannequin Study, which was conducted in partnership with San Diego Naval, which employed a larger simulation study supervised by the American College of Surgeons, who identified that through this various simulation study, there really wasn't a lot of training in existence in the context of simulation for airway management. So this particular project identified a need for endotracheal intubation training, cricothyrotomy training, and needle chest decompression. This was reinforced by the fact that in existing data from the Department of Defense, there is a need for both female and male patients, because in the context of training, or rather in the context of real clinical data, they find that female patients are experiencing fewer needle chest decompressions on site, which is resulting in poorer morbidity and mortality. And that's a consequence of the male medics that are reluctant to address the torso area of inspection when doing their evaluations of downed colleagues. So we wanted to ensure that we had both a female and a male data set to replicate and build out our simulators. So the simulator development process started with a requirements capture process and cognitive task analysis in consultation with the Medical Simulation Training Center, the MISTIC, as the Department of Defense enjoys using their acronyms, personnel at both the Joint Base Lewis McChord and at Fort Hood, as well as with medical professionals here at UWMC. So in the interest of completing this requirement capture, in addition to hitting the endotracheal intubation, cricothyrotomy, and needle chest decompression in the simulator, it had to be clinically accurate to the point where we were able to access all of these skills without compromising any of the anatomy. So we wanted to make this as high fidelity as possible, with the intent that the higher fidelity model will convey higher complexity skills in the training setting. So we wanted everything about AJAMS to be as anatomically to spec as possible. And that is an overwhelming theme through the course of the work that the CREST lab does. And we'll talk about that a little bit further in the slides to come. In addition to the anatomical and clinical accuracy that these models or this simulator had to convey, it also had to convey automated assessment by means of the advanced modular mannequin core and biogears. I will talk a little bit more about the advanced modular mannequin core and biogears in the slides to come, but basically this had to be a smart mannequin rather than the conventional dumb one that would be reliant on an observer to score the performance of a trainee. And beyond all of these things, the simulator had to be functional and usable in an austere setting. This was funded again by the Department of Defense, so it had to be usable in an austere setting. So in terms of the accurate simulation of the clinical procedures, as I alluded to before, this had to support the use of a bag valve mask, airway adjuncts like an iGel, and an endotracheal tube. It had to be able to support cricothyrotomy with convincing results, and it had to support primary and a secondary needle chest decompression, both on the right and left side. So here I'll just pause for a second and introduce you to the female version of AJAMS, which is this is actually a CAD drawing. It's not the actual AJAMS. You'll see that later. But this was developed by DJ Traina, one of our wonderful mechanical engineers. So as I said, this is a CAD image, and DJ would later build this physical image, build this CAD image into the physical AJAMS. And it was built completely on spec. So I'm talking about real human data sets, CTs and MRI images of real humans that were used to compile the entire AJAMS form. So the entire mannequin is built based on the morphology of an individual, both in the male setting and in the female setting. So these are basically one-to-one replications of a human with all of the mechanics of a simulator built in. So very cool. And as kind of alluding to, as I was saying before, the interest of maintaining the anatomical properties of a human in this simulator is presented here for you. So this is not only the case in the visual here, but it was also imperative that this reliance on the actual anatomy, or the representation of actual anatomy, was consistent not only in this visual that you see here, but also in the airway. So speaking of the airway and the actual accurate simulation of clinical procedures, 3 discrete airways were created and implemented into this existing simulator. There was an airway for intubation with airflow, an airway for suction with intubation without airflow, and a cric with airway. So in the context of the intubation with airflow, it had the capabilities to support intubation, the bag valve mask, and an LMA, as well as external ventilation. So this automatically allowed it to recognize airflow, which facilitated chest rise, which we'll see shortly. And it recognized, upon insertion of the ET tube in the correct position, the recognition of whether that ET tube was in the correct position, or if it was in a right main stem or an esophageal intubation. In the context of the cric with airflow model, it had manual capabilities to support the cricothyrotomy as well as oral suctioning. And it also allowed for the recognition of airflow through chest rise and the recognition of correct versus right main stem bronchus insertion of the E2 tube. And in the context of the suction and intubation airway without airflow, it supported oral suctioning, endotracheal suctioning, and the placement of the ET tube. It supported chest rise when under scenario or in structure control. So it did not have the automatic ability based on the structure of this particular airway to detect the placement of the ET. It was very much an observer required stimulus to encourage the chest rise. So a little bit of a caveat there, but still very happy with the way that that turned out. And again, built directly to spec with the existing data sets that are out there. And if you look in the literature, you'll actually find that all of the existing simulators that are currently in use for airway management are actually very poor in terms of volumetric analysis of the airway. And this, based on the fact that it is built based on existing data sets, we're confident that it is a much truer anatomical model of existing airways. In addition to the airway itself, we were also very attentive to the needle chest decompression sites, which we adjusted very specifically to the MYSTIC specifications, including the 2 sites in the midclavicular and the anterior axillary fifth intercostal space. So you can see them kind of here illustrated in pink, and these are actually positioned subdermally so that they're not readily obvious to the trainee. A lot of times when you're looking at mannequins, you can see where folks have existing tread lines where they've inserted needles. You can't see that in the case of the mannequin here because they are positioned subdermally. So there's no automatic cue as to where you think you should put that needle. These sites also provide feedback to the user, which is really cool by indicating a correct placement with a whoosh. When you insert the needle in the correct area, there is a whoosh of air that is presented to the trainee, and it's audible. So you can fully hub a needle in that particular spot, and the chest rise will return as would be expected in a real needle chest decompression. In the case of an incorrect placement of your needle, you will get subdermal tactile feedback. You won't be able to puncture the skin into the rib cage, which again is accurate to a clinical presentation. I spoke earlier about the determination of the CREST lab to adhere to existing anatomic presentation. So one of the projects that was a sub-project of this was the optimization of the puck, which is that particular little pink area, which I alluded to here, ensuring that that little puck was the correct tissue characteristics that would emulate the intercostal space on a human. So this is just some of the work that was done by 2 of my colleagues, Alex Gong and Jason Spike, our respective human tissue characterization lab manager and our tissue analog characterization manager, who worked together to study the human tissue properties, tension, puncture force, etc., and create tissue analogs based on those data that emulate the human tissue specifically. So this is just some of the work that's particular to the puncture force. So Alex's work to find that the puncture force required for human needle chest decompression is between 2.5 and 4 newtons. And then Jason created a plasteel gel with mineral oil that exactly replicate that, or replicated it as best as possible to feel like the needle decompression that you would feel in the intercostal space. So this is just some of the force and displacement graphs that they've used to represent different concentrations of mineral oil within silicone to replicate that particular force that would be experienced by a clinician upon insertion. Similarly, these 2 also did similar work in the context of the cric. So characterizing the cricothyroid membrane for puncture in the cricothyrotomy. So here you can see there are more graphs that you're seeing force over time, comparing the human tissue, which is like illustrated here in the black, versus an assortment of other different synthetic materials. And you see here this purple line indicating that the one that they ultimately selected, which was basically Scotch tape, your 3M Tegaderm CHG, which is low cost and easy to use, and certainly provides a appropriate haptic feedback that emulates the cricothyroid membrane in this context. So through a series of controlled experiments, they were able to identify and define exactly which type of membrane they best represent the cricothyroid membrane in the human. As I alluded to previously, the concern around the addressing and preparing medics to address and assess females with experiencing torso injury, the integrity of the breast tissue on the female mannequin was also of considerable concern. It was imperative that the mannequin replicated realistic and fluid movement of the breast to elicit the trainee reaction during the needle chest decompression procedure, because at that secondary site, you need to engage with the breast to reflect, to access that mid-axillary line. So some of the work that the lab did was really focused on this breast to really optimize that tissue movement so that it would create a realistic experience to prepare those trainees to deliver care to an injured female warfighter, basically. So that was another piece of the anatomy and fidelity puzzle that was very important to the CRUS lab, increasing fidelity in this context. Okay, so that's all of the clinical piece, the anatomical piece, and ensuring that fidelity was high in this context. The second piece that was very important was the automated assessment and the smart features of this simulator. So this is the baby of David Hananel here, pictured up in the right-hand corner. This is a very complicated and elaborate system. And the best way that I can feel to describe it is that this is the operating system. So we're all familiar with how an Apple operating system runs. Like, this is the software that governs everything. It interacts with the hardware. You can add peripherals that are specific to that operating system. It basically runs the show. That's essentially what this is, the AMM core, the Advanced Modular Mannequin Core. This is the software that runs the mannequin. It allows for different plugins. It allows for different peripherals to be integrated into the existing mannequin. And this is open source and previously funded by the Department of Defense, and is becoming the gold standard for use in the simulation design space. Because it's open source, anyone can use this technology integrated into their peripheral, and that can plug and play and work with other simulators. So for example, the AJAMS, which I presented earlier, didn't have arms attached to it. But if you wanted to create an IV arm, all you would have to use would be the connector, which is open source, and this technology, which is open source, and you could then have your IV arm connect to AJAMS, and you'd be able to use them without issue. Another piece of this puzzle is a learning record store. Another piece of this puzzle is also biogears, which is illustrated here. And this is the work of my colleague, Austin Baird, who's here in the division. Both David, Rob, and Austin are all my colleagues in the Division of Healthcare Simulation Science. But biogears is a further Department of Defense funded open source technology, which is a physiology engine. And I'm not sure if you're familiar with that terminology. I wasn't up until the time that I came to UW. But biogears, the physiology engine, is a series of algorithms which calculates human response to interventions. So for example, this works through the iOS of AMM to create a response in the mannequin through actuators, et cetera, that would be characteristic of the response physiologically in the patient. So for example, if you push or tell the system that you're pushing epi, this would respond appropriately to epi with the increase in blood pressure, the increase in heart rate, et cetera, et cetera. So you'd have all the physiologic cascade that would be represented in a patient represented here. So they've got a series of systems that are populated and validated to show that it's the correct response. So you can throw your different administration of different kinetics and dynamics. You can address the renal system, the gastrointestinal system, the cardiovascular system, the respiratory system, the nervous system. They're still working on the nervous system a little bit, but the endocrine system and the essentially the range and the connection of the various systems is extensive. So you can work with Austin or take this on your own if you have mathematical skills, significant mathematical skills to prepare the simulated patient to respond in a way that a human patient would respond in response to these various interventions. So it's a very powerful technology, and it was imperative that we had this on board so that we could create the condition for chest rise and essentially make it future-proof in the event that anybody wanted to, again, hook up that IV arm or simulate a pneumothorax or anything of that nature moving forward. So as I alluded to previously, it had to provide automated assessment, and the primary metric in this context was chest rise. And this chest rise was created or made possible by some very cool mechanical activity that was administered by DJ Trena by way of a steel hinge assembly for smooth and reliable actuation. So when that endotracheal tube was positioned correctly in the perceived main stem, it would not chest rise, or we might have an asymmetrical chest rise. But when it was positioned correctly, we would have that nice symmetrical chest rise that would elevate for approximately 45 millimeters of unilateral or bilateral within the, which is in fact within the standard patient range. So this is just kind of another cool view of what you're getting here with AJAMS. Now, okay, so it had to be clinically accurate, anatomically accurate. It had to be smart and allow for assessment automatically without an observer, and it also had to be functional. So it had to be usable by simulation technologists, and it had to be usable in an austere setting. So in order to allow for all those things, we had to have removable teeth inserts because they're probably going to break the teeth. We had to have swappable airways that were easy to swap, so that, because remember we said there was those 3 of them. It had to be so easy that an individual could do it without significant training, because if you need significant training for that, nobody's going to use it, right? So it had to be easy to swap in and out. It had to have integrated handles so that you could pick it up and move it without significant challenge. Opposable shoulder joints, if you wanted to put those IV arms and then abduct or adduct the arms, they had to have that functionality. The realistic breast tissue that I was alluding to before, it had to have an anti-skid backplate so that when you put it on a table, it wouldn't slide all over the place. Fan vent for cooling, had to have a little user interface so that people can control exactly what's going on, see what the battery life is doing, all that kind of stuff. Very much usability perspective. Opposable hip joints if you wanted to throw on a leg, and the universal segment connectors, so that, again, if you want to have additional limbs attached, it had to be able to do that. And in addition to that, it had to be tetherless, because again, if we're dealing with an austere situation, we don't want to be looking for a plug. So Reiner here, which is our control systems engineer, terrific guy, integrated 2 smart batteries into the system so that this can be completely wireless and run for 8 hours without any interruption. So through all of this effort and quite a bit more that I didn't elaborate on because this project was 5 years long, ultimately it yielded 2 one-to-one human analogs for both male and female data sets. So one-to-one based on anatomy as close as possible that would simulate the endotracheal intubation, cricothyrotomy, and needle chest decompression, provide that automated assessment, and is functionally usable in an austere setting. Whew, that's the first part. And that ultimately yielded this here. So you can see, here's the female AJAMS in action with training with the King County Medic 1 EMTs. So we can see here preparations for an endotracheal intubation. We've got inspection of the mouth and a very mobile mandible, as you can see. Interaction with the bag valve mask. Now we're going in. Trying with the eye gel. Video laryngoscope. And we'll do a cric. The cric pucks are really cool. I didn't get a chance to illustrate that for you, but it does have a little blood pack. So it does ooze a considerable amount of blood very convincingly to add to that fidelity, which has been very well received in anecdotal evidence by the King County Medic 1. So now looks like we're getting in there, and hopefully we'll be able to see some chest rise very shortly. And there we have it. I think you can appreciate the mechanical chest rise that is quite nice looking. Oh, just gonna keep playing. Okay, so that takes care of the big development piece that I felt prudent to explain and describe to you before we talked about this the two studies, because I can't just jump into this discussion of studies without explaining to you the intervention. So that is the design piece. Now we'll talk about the evaluation of physical fidelity, all that time and energy that we put into the development with attention to the anatomical structures as presented by 3 different airway management simulators. So basically, how does the fidelity of AJAMS compare to 2 commercially available airway management systems as assessed by master airway management specialists? So what is fidelity? So the operational definition that I'd like to adopt here is the extent to which the appearance and behavior of a simulator or simulation matches the appearance and behavior of the simulated system or work environment. Beyond that, Diekman et al., they like to define a conceptual framework around fidelity. So they define fidelity as having 3 different areas: the phenomenal area, semantic area, and the physical or the engineering domain. So I think you can probably infer that we're probably going to be talking a lot about the physical domain, but I'd like to further define those 3 just for you so we're all on the same page. So in terms of Diekman's description, we have semantic fidelity, which refers specifically to the logic and content of the system. So is the information that's presented in this simulation or in this scenario reasonably interpreted, even if the physical basis to transport that information is not realistic? So are the sequence of events appropriate, even though it may not be what's actually happening in a clinical setting? So it's like, does the blood pressure drop in response to mass hemorrhage? That is a logical sequence. So yes, you would expect that is the semantic fidelity is intact. If the blood pressure doesn't drop in response to hemorrhage, that is low fidelity in response in the context of semantic fidelity. So it's really the logic and content of the scenario. There's the phenomenal domain of fidelity per Diekman, and that really refers to the relevance. So it's talking about the participants' emotions, beliefs, and understanding of how the event pertains to their own education and professional development. So essentially, it's buy-in. So does this situation feel important enough to me to participate in and to buy into it? If the team that an individual is working in is very laissez-faire about the situation, they're not interested or engaged, or they don't see how this is important to them in their day-to-day work, the phenomenal fidelity is low. If the whole team is gelling together and they recognize that this is very important, then the phenomenal fidelity is high. And then we look at the physical domain of fidelity, which Diekman kind of poo-poos on this globally, but there's a lot of work out there that suggests that the physical domain is particularly important when we're talking about complex skills, which is why we're interested in it here, given that endotracheal tube intubation is perceived as being a complex skill. So physical fidelity per Diekman here is described as the elements within a scenario or in a simulator that can be physically measured in a fundamental and physical term or a clinical term using measurable dimensions. So these are concrete pieces like, does this feel like real? Does it feel realistic? Does it look realistic? Does it behave realistically of the setting? Is this room what I would expect this an operating room to look like, for example? Does this patient feel warm to the touch? Because you would expect a patient to feel warm to the touch. Basically, it's any concept that is impeding the suspension or promoting the suspension of disbelief to allow for you to believe that the simulation is real. So that's engineering fidelity, manipulatable constructs that are important in the context of representing the simulation. So within CREST, we like to flesh out that physical fidelity a little bit more. So I'll just kind of explain, and I kind of alluded to it in the past slide, but the 3 domains that we have defined based on physical fidelity are the visual, the tactile, and the behavioral domains. So The visual domain refers to the physical attributes of displaying visible geometry, symmetry, or other properties demonstrated in a real environment. So does it look real? The tactile environment, particular to the temperature, the texture, properties of friction, weight, all that kind of stuff. Does it feel real? And behavioral element, or the behavioral domain, which is the physiologic characteristics and adherence to the physical laws demonstrated in a real environment. So does it behave the way you would expect? Does the tongue flop back and get in the way like a tongue should? Does the physiology respond in a way that would be appropriate? All that kind of stuff. So we're talking about visual, tactile, and behavioral in the context of physical fidelity here. And naturally, because this is a heavily engineering-based group in the CREST lab, these are very important when we're trying to replicate clinically and anatomically accurate representations of the human form. And as I alluded to before, this seems to be particularly important in the literature when training with complex tasks. There's a lot of discussion about you don't need to have high fidelity for trainees. It's overwhelming. It's too much cognitive load. They can't acquire the skill. When it's too much fidelity, they just need a simple model. What we are proposing is that in the context of complex tasks where you have advanced skill practitioners, they need this fidelity to buy in, to apply their knowledge, and to complete the task successfully. So the magnitude of the effectiveness of the simulation as a learning experience is thought to be proportional to the precision of the simulator's ability to replicate the real world experience. So bearing all that in mind, the aim of this particular study, study 1, is to assess the physical fidelity or the realism of 3 airway management skill trainers in terms of how closely they look, feel, and behave like a real human airway. And secondarily, we wanted to assess the educational utility of each of these 3 airway management trainers. So how did we do this? We designed a prospective observational study housed at the Bellevue Fire Department with their EMTs, and we solicited 12 experienced paramedics with considerable practical knowledge of emergent airway management and the human anatomy of the airway. And we asked them to do endotracheal intubations on 3 different simulators. So the endotracheal intubation, which, as I'm sure you're aware, is a medical intervention in which we place a tube into the trachea by way of the nose or the mouth. In the context of the study, we did oral only. It's a potentially life-saving intervention, but it carries risks, certainly, especially if executed incorrectly. So there's a high risk of morbidity and mortality, and that's a challenging task when healthcare providers are faced with it. But unfortunately, there's not a uniform mechanism of training for ETI. There's animal models, there's synthetic models available, but every model that exists does have limitations, both in terms of fidelity and translatability, and cost and logistics. So, and as I alluded to earlier, even the highest fidelity models that are out there right now seem to be anatomically inaccurate based on volumetric analysis. So that anatomic variability can essentially threaten skill transfer, because if you're working on a model that's not anatomically accurate, you're used to having a whole lot of room. When you get into the airway and you don't have a lot of room, you may not be as good as when you trained on the other model. So that's suboptimal. So having an anatomical airway which is accurate of a human airway is essential. So we proposed that would be of use in this training context. So as I alluded, we had 3 different airway management trainers, which are currently commonly in use in the training sphere. We had the Laerdal, which is at the top, the TrueCore in the middle, and then AJAMS at the bottom. So all of our skilled expert airway management specialists engaged with each one of these different airway management simulators in a randomized assortment. And they completed a data collection instrument assessing the anatomical fidelity specific to endotracheal intubation using a purpose-built data collection instrument that we used, which leveraged a visual analog scale. And that visual analog scale ranged from 0, which is not at all resembling human tissue, to 100, which is an exact replica of human tissue. And we posed these questions for each of the domains of fidelity that we proposed: visual, tactile, and behavioral, and for each step of endotracheal intubation, where we highlighted the relative anatomy that was presented in each context. So essentially, the paramedics would go through, the EMTs would go through, they do their intubation, on one of the simulators, and then they'd complete the battery of questions specific to that trainer. So how they'd evaluate the visual fidelity, the tactile fidelity, and the behavioral fidelity for each one of these steps. So they'd rank them overall, and they would go through for each stage. So in terms of positioning the patient, they'd be evaluating the head, the neck, the trachea, the sternal notch, the ears, and the mandible for their visual fidelity, for the tactile fidelity, and their behavioral fidelity, and so on, for inserting the laryngoscopic blade, for inserting the endotracheal tube, and for verifying successful ventilation. So we had a large pool of data that came out of that. So we proceeded with a one-way repeated measures ANOVA, which was appropriate for within group differences. We threw on a Bonferroni pulse talk analysis to allow for multiple pairwise comparisons for each level of the within group contrast, so between the different simulators or the trainers, and for each dimension of fidelity and the procedural stepwise contrast. We then did a non-parametric Friedman's for the ordinal or rank data that was specific to the educational utility. So when they were completing, or when they had completed all three simulators and completed all of their data collection for those, we asked them to rank their perceived educational utility of the trainer. So which one of these is number one, which one is number two, which one is number three? We used a Wilcoxon signed rank for the pairwise comparisons corrected with a Bonferroni. So these findings are the findings that every researcher is very excited to see when they're presenting the work. So here we have the overall findings for the Laerdal, the TrueCore, and the AJAMS in comparison in each one of the behavioral, tactile, and visual domains. As you can see here, overall landslide in favor of AJAMS. When we pull that out, particular to the visual fidelity on the left, the tactile fidelity in the middle, and the behavioral fidelity on the right, we can see a little bit more clearly exactly what we've got going on here. So essentially, trainer 1 and trainer 2, which are AJAMS, which are Laerdal and TrueCore respectively, are about equivalent. There's no statistically significant difference between those in the context of all the domains of fidelity: visual fidelity, tactile fidelity, behavioral fidelity. They're kind of behaving in the same manner, presenting in the same manner in terms of anatomical fidelity. But trainer 3, which is our AJAMS, is head and shoulders above as perceived by these master endotracheal intubation specialists, as you will. So statistically significant difference between AJAMS and the existing commercially available simulators. And this is maintained over the course of all 4 of the steps that we indicated: the positioning of the patient, the insertion of laryngoscopic blade, the insertion of the endotracheal tube, and the verification of successful ventilation. These trends are very, very apparent and statistically significant, suggesting that, as perceived by the airway management instructors with considerable expertise in this domain, the anatomy that's conveyed by AJAMS is far superior than that which is out there available. In the context of educational utility, which was that last question where they ranked the 3 options, there's no surprise here. There was a statistically significant difference in educational utility across the 3 trainers, favoring AJAMS. Laerdal and TrueCore were approximately equivalent, but statistically speaking, AJAMS was far and away the preferred educational model for these instructors. So in conclusion, based on that study, the AJAMS trainer conveys way more anatomic fidelity, both overall and in each dimension of physical fidelity, visual, tactile, and behavioral, than the 2 commercially available trainers. This was evaluated by the individual skill and the performance of any instruction of airway management skills. Of course, this wasn't a randomized control study, but that wasn't the nature of this particular study, so small limitation there. But I think that this is an interesting and encouraging step forward to assess, at least Kirkpatrick's level 1, the attitudes and perceptions of this particular educational intervention. So I spoke of Kirkpatrick's level 1, so we have to speak of Kirkpatrick's level 2, right? When we talk about training and the intervention and the development and intervention of a simulator. So in study 2, we moved on and took it to the next step in context of endotracheal intubation performances in novices. So we wanted to compare the training effect that resulted from 2 airway management training simulators. So in this context, we wanted to see if AJAMS or how AJAMS compared to a conventionally available simulator, the SimMan Essential, in terms of the proficiency in intubation skills, in terms of critical errors, and the time to successful intubation. So those were our three aims. So does training with AJAMS improve these three things compared to the SimMan Essential training paradigm? So we created a parallel group randomized control trial, and that was executed at Harborview Medical Center last summer. And our participants were newly enrolled paramedic trainees with limited practical knowledge in airway management and the anatomy of the human airway. This was actually executed on day 2 of their enrollment. So they had their first day orientation and then they came to us. And that was a really great experience working with the King County Medic 1 paramedic trainees. So in this context, we were focusing again on endotracheal intubation. So here's a breakdown of the study, essentially. So we had a total of 20 individuals, 2 groups of 10. We had to remove 1 individual because that individual didn't allude to the fact that they had some significant experience with endotracheal intubation, so we pulled them out. So it's really 1 group of 10 and 1 group of 9. And we baselined these individuals. As I said, they had no prior experience, but we wanted to make sure that our groups were equivalent. So we asked them to do baseline testing that was particular to endotracheal intubation. So we used fresh frozen cadavers. We asked them to complete an endotracheal intubation, and we recorded the time and we scored them. So they were under video recording during that period. And then we had asynchronously 2 skilled raters assess their performance using a checklist, which has supporting validity and reliability evidence for this context. So they did their endotracheal intubation, and then we had them randomly assorted into groups. We had our control group, which was training using the conventional simulator, the SimMan Essential, and we had the treatment group, which was the training using AJAMS. The training was a period of an hour and a half, using 1-to-1 with a skilled airway management specialist who's conventionally training the paramedics in the skill of endotracheal intubation. And then we did a post-test. So as soon as they were done that hour and a half, they came back into the skills lab and they completed an endotracheal intubation again on a fresh frozen cadaver. Prior to each the baseline and the post-testing, we did collect the Mallampati scores to ensure that we were able to control for intubation difficulty off the hop. And as I alluded to previously, the performance videos, the individuals completing the endotracheal intubation on the cadaver, were assessed asynchronously by our trained raters using a valid and reliable ETI assessment tool. And yeah, as I said, they were in the training sessions with master clinical instructors, and those master clinical instructors were using a structured existing curriculum to support the training to ensure uniformity in training conditions across the 2 groups, so that we couldn't really attribute any differences to the difference in the instructor quality. The instructor quality was uniform based on that curriculum. So here we just have a quick picture of the comparison. We have AJAMS on the right, and we have the Laerdal SimMan on the left. So those are our 2 groups. So we did a statistical analysis, which is a 2x2x3 factorial. So the first 2 being the group, so novel versus conventional training, the second 2 being time, baseline training versus post-training, and the 3 being airway score. So was it a 1, 2, or 3 in terms of the Mallampati scores? So this ANOVA is utilized to address the key metrics. So we had 4 here: overall endotracheal intubation score as per the raters on the valid and reliable assessment metric, the number of errors occurred based on that metric, the number of critical errors incurred, and the total attempt duration. So we ran one of those ANOVAs for each of those dependent measures. And then we did post-hocs, our post-hocs, and we didn't have to correct because we didn't have multiple comparisons after the fact. So while study 1 was very, very encouraging, study 2 is a bit more difficult for a researcher to present. Ultimately, we did not see significant group-wise differences. There were no interactions observed in any of the data that we collected. Ultimately, what we observed is that over time, everybody improved with training. which is great. It would be spurious if they didn't. So the ANOVA revealed significant performance gains for both of the groups, but nothing particular to one group over the other. So no interaction effects in the context of overall proficiency. The same can be said for errors incurred, for critical errors, and for attempted duration. So a bit annoying for a group that's particularly invested in the fidelity of the simulator. Both training conditions yielded favorable improvement between the baseline and post-training scores. So training is helpful regardless of the modality, even over a short duration, so an hour and a half. But silver lining, we can say that AJAMS presents a training effect that's at least equivalent to the conventional training model. So it does have great potential, but perhaps that wasn't elucidated here. So we suggest that further inquiry is merited here to assess the impact of training using this high fidelity model. And we would like to do so using larger training cohorts, because this study is innately hampered by low sample size. And our analyses after the fact did represent the fact that it was very low powered, and that's not really a surprise because we went in with the intention of having a total sample size of 82. But unfortunately, because of the pandemic and because of population challenges with this training group, we were not able to hit that sample size target. So we would love to continue this study to see what a larger sample size bears out, because the trends in the data do suggest that it could be a very valuable and exciting opportunity to increase both clinical skills transfer and long-term retention. So that's kind of where we're sitting right now. Those are my references. And this is the CREST team who have done all of this terrific work up to this point. So major kudos to them. They did a lot of the heavy lifting, and I came in and evaluated it all. And unfortunately, in study 2, didn't have great news for them, but I thank them none the same. And I thank you for listening to me prattle on for 50 minutes. And I hope that if you have any questions, I'm able to answer them for you. Thank you so much.
Dr. Roach, thank you so much for joining us. I actually found some of this very fascinating. I have a question, but I'm going to actually open it up to groups. So if anyone wants to actually ask a question, please go ahead and do so. And I'll chip mine on after that. And then I'll also monitor the chat if anybody wants to put a question there as well.
Great. I'm going to stop sharing just so I can see people if they're asking questions.
Well, maybe I'll go ahead and get started. What I thought was fascinating, I mean, the sort of the appearance, even in just your video and the images, is really just startling and fantastic to see that trainer. You know, the one question I might have for you in just looking at the 2 studies, you know, I do a lot of training with the medical students every year in the transition to residency course, and we do cricothyrotomy, we do chest tube placement, etc. You know, I don't know, I'm sure you've probably considered this, but the difference in looking at the other trainer, which, you know, clearly, even just in gross visual, has far less fidelity, yes, versus, you know, AJAMS, which is amazing. It may be a question of who your learner is, right? If you're teaching somebody who has no experience and you're just trying to get them basic familiarity, the sort of high fidelity may not add a substantial impact for that person. Yep. But I'm curious if you're planning to do maybe a study with much more advanced learners. So for example, you take an anesthesiology resident who is who's already well into training, let's say 2 years into training. And instead of just basic intubation skills, you give them challenges, right? So the higher fidelity model has the potential to give them, you know, more challenging data feedback, right? For challenging situations versus just basic intubation. So I'm curious if you guys, I would assume you probably talked about that and how that might actually change the outcome of the study. Yeah, absolutely. And great question and comment. I kind of alluded to it in the fact that it's the higher fidelity is more important for complex tasks, but I think it's more, as you state, for whom, right? So it's not necessarily that the task is complex, it's that the learner needs the anatomic cues to support their completion of the advanced task. So it's possible that there was a mismatch here in that
because these were trainees, they were still experiencing that cognitive overload that was presented by this really impressive model, and they could have probably done just as well as the data suggests using a lower fidelity model. And as you suggest, I think it would be a great study to see the context as applied for anesthesiologists who are doing this all the time. So this is their bread and butter. And if we throw them a particularly difficult airway, which is something that we're discussing, possibly encouraging swelling of airway tissues, could this be something that is really valuable in that context?
I had a question, Dr. Roach. Thank you so much for sharing your incredible work and the validation studies. It was a fantastic presentation. Similar line of questioning to Dr. Marquardt's question. As you pointed out, the difference in fidelity for the novice trainee versus the more expert trainee is very visible and palpable as we train our trainees on simulators. The novice is just trying to figure out, what the controls are and just get the task done in a timely manner. And the expert trainees start to complain about how the simulator doesn't really reflect real world.
Yes.
So to Dr. Marquardt's point, what the model that you have, which is incredible, did the experts that evaluated the model, did they tell you what percentage of trainees would be covered by this, and what advanced clinical scenarios would be outside of this model? And were there any anatomic, because there's so much anatomic variation as one might imagine with the spectrum of patients that we see. Are there modifications to the model that could be made without having to create 3 or 4 different models altogether? To cover all the spectrums of the difficulty in terms of fidelity?
Great questions. I'll speak to the first one. The master instructors did not allude to the percentage of the trainees that they think this would be particular to. They just wanted to use it for everything. And they are currently. So the Medic One has invested in 4 AJAMS modules, and they're currently using it particularly for cricothyrotomy right now. Less so for endotracheal intubation, but that's just because they have more exposure to endotracheal intubation in a regular setting, whereas cricothyrotomy is a low frequency event that they want to address. So in particular to numbers and proportion of the trainees that they expect this would be useful to, they didn't address that specifically. The second part of your question, the potential to emulate different anatomy, absolutely. Because of the nature and the design of AJAMS, everything's modular. So we are actively looking to develop like a thick neck, or we could do a beard, or we could do a short neck. That one would be a little bit more involved because we would have to work on the internal chassis of the simulator. We'd probably need to solicit some significant external grant funding and do a continuation to support that. But we are looking at different modular opportunities to emulate different anatomy that could make intubation more challenging or different for the trainee. Absolutely. Thank you.
And one additional question, this model is so fantastic. It looks like you're already applying it to the EMT folks, but can you comment about mass production and commercialization of the product?
I would defer that question to David Hananel, who's taking on, he's right here, actually, he's in the room. I know that they are soliciting additional opportunities to commercialize and make possible the access of AJAMS to everyone. But I don't think I'm in a position to comment more than that.
I don't know if David wants to comment on that. Maybe we won't put him on the spot if he doesn't want to.
Oh, he's unmuted. Go for it, David.
I'll just give you a short summary. I guess it's always a challenge to move IP out of a university into the commercial world. So it's almost like a trial. We created a small startup. We just finalized moving the IP from the university in the startup, and we're trying to identify vendors that could produce the various components of this and see if it is really commercially viable to introduce it as a trainer out in the marketplace. It'll probably take about 9 to 12 months to see if that will fly or not. So that's the current state.
Well, we certainly hope that that does move forward, because it really does seem quite fantastic. I have a question in the chat. This is from Dr. Sarah Kim. She says, thank you for the excellent presentation, very rigorous simulation-based evaluation approaches. She says, I'm curious to hear about your experiences in working in teams of multidisciplinary colleagues. What's been the main reward or challenges experienced in that process?
Great question, Sarah, and thank you for waking up early to attend the talk. We much appreciate it. Interdisciplinary teams, absolutely. I am very team-based in myself, and I thrive in a team-based environment. I really value the diversity that a team brings. It's something that it's really opened my eyes coming to Crest and being able to work with artists and engineers and sculptors and digital anatomists and a whole different world of folk that share a very different worldview than I do. So that has been really refreshing. In terms of folks outside of that academic sphere, we did have collaboration with JBLM and with King County Medic One, and both groups were terrific to work with. However, there were significant administrative challenges in working with the military, and that's through no fault of their own. Obviously, there are additional logistical challenges in working with the military. So that would have been the largest challenge, that we had to navigate the administrative challenges of working with JBLM specifically. But on the other side of the coin, King County Medic One were extremely nimble, flexible, and energetic, and encouraging continued collaboration with us. So that was a wonderful, wonderful opportunity that they were quickly able to help us get raters, help us get participants, help us get instructors. Really, they showed a great deal of enthusiasm and commitment to this work. So that was a really wonderful experience. So bringing their clinical knowledge and bringing their personnel was very, very valuable.